Welcome everyone, and thank you for attending today's webinar. 2020 is fast approaching. Are your health IT workflows ready for change? Sponsored by EFACS. My name is Mike Milliard. I'm editor of Healthcare IT News, and I will be your moderator today. The interoperability challenge of exchanging information among healthcare providers' medical record systems is not being solved fast enough, which is why fax is still the common denominator for communications within and between providers and payers in the healthcare industry. But times are changing. Alternatives exist that can provide a safe and secure transfer of health data. So today you'll hear from Brenda Hopkins, strategist for J2 Cloud Services. Brenda provides strategy for J2 in the area of healthcare interoperability, where she's focused on open data exchange of healthcare information inside and outside of the EHR, and using open platforms and tools such as APIs as a means of sharing. So with that, I'll hand it over to Brenda to begin our presentation.
Thank you, Mike, and welcome everyone. As Mike said, we're going to talk today about cloud communications and interoperability. So with that, we're going to jump right ahead to our agenda. Today we're going to talk about CMS and the call for healthcare modernization and the move to a paperless office. We're going to talk about the solutions that eliminate the fax machine from the physician's office by 2020. How cloud communications eliminate the fax machine now, not in 2020. How direct secure messaging will play a key role in bridging the gap. Why APIs are the key to EHR integration. And how cloud fax promotes interoperability between health record systems. In a speech at the August 2018 Office of National Coordinator for Health Information Technology, the ONC's Interoperability Forum, the Center for Medicare and Medicaid Services, CMS Administrator Seema Verma said that while the rest of the world is rapidly adopting the latest digital technologies, healthcare seems to be stuck in a 1990s time warp. The federal government has spent over $35 billion on an effort to get doctors to use electronic health records, new technology that is making their work more difficult, not less, causing more physician burden and burnout. But the initiative did not align with having these purchases directed toward sharing information with each other. Because of it, doctors today are still recording their notes on paper, and they are still faxing patient records. Verma said, if I could challenge the developers in this room here today to achieve one mission, it would be this: help us make every doctor's office in America a fax-free zone by 2020. Today we have systems that speak different languages, information is not communicated, records are not interoperable, and patients and providers don't have access to the information they need to make better decisions. The Blue Button 2.0 initiative from CMS is an API that contains 4 years of Medicare Part A, B, and D data for 53 million Medicare beneficiaries. This is part of a larger interoperability strategy that Seema Verma was also proponing at the ONC conference. The data reveals a variety of information about a beneficiary's health, including the Medicare coverage, the drug prescriptions, primary care treatments, and costs. Beneficiaries also have full control over how their data can be used and by whom, with identity and authorization controlled by mymedicare.gov. The Blue Button uses HL7 FHIR standard for beneficiaries and the OAuth 2.0 standard for beneficiary reimbursement. As part of the larger strategy to encourage interoperability, Verma said that providers will experience reimbursement reductions if they don't provide patients with electronic access to their health information. In March of 2018, Verma unveiled from CMS a plan to completely overhaul and replace meaningful use with one called Promoting Interoperability. Physician and clinician feedback from Verma's speeches included mandating a stop to fax machines use should not be the process. Improving interoperability and coordination of systems should be the process. Fax machine use should not be mandated, but better allowed to fade away on its own, while coordination of interoperable systems causes fax machines' use no longer to be needed. If faxing works for them, why do we need to force them to change and invest in new technologies? Are you also going to propose the government provide the funds to these offices who need to make these changes? Remember, this decision will impact small businesses. For health systems that want to cut the cord on faxes, they can't just decide to quit faxing at once and be done with it. You can't just say, no faxing now. You have to set a date and create a work plan. How CloudFax can eliminate the fax machine and help in interoperability? Many people are calling for the end of faxes in healthcare. The problem with this is that when you slam faxes, you're slamming the most interoperable piece of healthcare today. That may be sad to hear, but it's true. Faxes aren't the problem. The lack of a better solution is. So instead of slamming faxes, we should better understand the qualities that make faxes the interoperability choice of healthcare. Some of the faxes' positive points are that they're HIPAA compliant. Case law and other HHS comments have declared faxes to be HIPAA compliant. That's not to say that faxes are secure. We could talk over whether it's secure or not, even edge cases where it's still not HIPAA compliant. However, what's clear to everyone in healthcare is that you can fax PHI and there's no HIPAA violation. At least that's the perception and how people treat it in action. And that's a powerful idea that can't be understated. Perception deeply influences people's behavior, especially in risk-averse doctors' offices. Published fax numbers are easy to look up thanks to Google and an online directory where you can search for any fax number. Faxes are standard. Unlike so many other healthcare interoperability standards, every fax machine knows how to call and talk with another fax machine. There's no need to ask what version or flavor of the fax standard you are using. There's no need to ask where you're storing certain information. Every fax uses the same standard and delivery. And every practice has a fax workflow. So let's look at how cloud faxing might help in this transition. First of all, what is cloud faxing? Cloud faxing is the modernized version of regular faxing. Online faxing sends fax in a digital format through your internet connection from your computer or mobile device, while regular faxing requires a phone line and someone standing over the fax machine waiting for your message, perhaps to be printed out. Benefits of online faxing are that there's no standalone hardware or software, there's reduced phone cost, there's added confidentiality, and that online faxes can be sent directly to your email instead of the office fax machine. It's email focused. They can cut the paper costs down, and also international faxing is no additional cost. Additionally, you can put together group delivery and mobility options with electronic signatures to add a more robust offering to enable what is now your fax workflows within your organization. What is direct messaging, and how does that play into operability? Direct's a national encryption standard for securely exchanging clinical health data via the internet. It's also known as Direct Project, Direct Exchange, and Direct Secure Messaging. It specifies the secure, scalable, and standards-based method for exchange of PHI. It was developed in 2010 under part of a federal project for standard-based healthcare communications. So who can use Direct? Hospitals, providers, clinicians, patients, laboratories, long-term care, skilled nursing, and dental, among many. How is Direct used? So in the workflows that we talked about for fax, Direct is also considered in transitions of care or care coordination using a CCD or CCDA document, using physician consults, MedRec, lab test results, order submission, or report distribution. So Direct can be incorporated into a variety of user interfaces as well, such as an email client, a mobile device, healthcare IT system portal, or as an automated data delivery feed. Any of these interfaces are capable of sending and receiving directs. But in order to participate, both sender and recipient user will need a specific direct email address provided by their HISP. Where can you get a direct address? You get it from a health information service provider. Many times those are a part of your EHRs as well. So some provider feedback that has been a part of the Direct initiative to help with interoperability and cloud communications is that, however, direct messages have taught us is a really important lesson about granular data, which also highlights why fax machines and fax are still popular and direct messaging is not. Machines love granular data. That's why machines are okay with a massive CCDA document that's chock full of data. However, those CCDA documents are almost impossible for a human to read and cause doctors to say that a CCDA is an abomination that doesn't improve care. So humans need healthcare documentation designed for humans and leave the XML health data for people who are working in machines. This is an illustration at a high level of how a direct exchange works. Direct's essentially email, but with some important key differences. Instead of an email SMTP server being maintained for the addressee subscribers by an employer or by an email provider like Google or Yahoo, an agent known as a health internet service provider, a HISP, handles the email exchange. The HISP also carries out the encryption and the decryption and digital signing of each message and attachment, shown here as a security trust agent box within each HISP. Note that each sender and receiver in direct exchange must have a unique direct address, but much like a regular email address, but with the word direct in the address line. In fact, this format for direct is not a mandatory requirement, but within the direct trust community, however, is a strong convention that's widely followed. Direct messages can have any file type. For example, an EHR vendor offers a HISP service directly to their customers, while other EHRs have partnered with standalone HISP to offer direct. A large healthcare provider or a hospital system may choose to be its own independent HISP, working with several EHRs and patient portals. There are personal health records that provide HISP accounts and addressing services for patients and consumers as part of their offering. The role of a HISP is fairly new in the market. It is understandable that there's several different configurations for the delivery of direct exchange that are evolving. The sending and receiving system in the illustration might be an EHR or a web portal or even a smartphone. Any device is capable of sending an encrypted message in one of several communication protocols to the addressee HISP, which is the HISP at the other endpoint. Any direct addressed endpoint will thus be capable of connecting via direct with any other addressee endpoint, whether within the single domain of a HISP or across other domains within HISPs. If you're a provider or a health professional or even a patient who is using direct, you really don't need to know much more about direct than what's captured here and in this illustration above. However, one thing that's very important to highlight is that you should choose to use a direct exchange that is certified and that the HISP you choose is to use in combination with that sending system is accredited by Direct Trust. I'm going to talk a little bit about APIs now as another form of interoperability and to help with communications. So healthcare organizations have created interoperability between internal apps and EHRs and other data exchange tools, and they're increasingly turning to application programming interfaces or APIs to manage that flow of information between disparate systems. As the ongoing transition to value-based population health management, and care coordination creates an imperative for actionable insights at the point of care. APIs can ensure the electronic health record is accessible to the right internal and external users while remaining protected from malware and outside threats. So we're moving out of an era of EHR implementation and adoption and into the era of interoperability, much like CMS is incenting from meaningful use to promoting interoperability. Now that we've automated the health record, the next phase is connecting all the information in the EHR. We need interoperability and open platforms to accomplish this, and healthcare stakeholders have started to invest in APIs to facilitate this vision. But what is an API exactly, and what interoperability challenges do they help healthcare organizations overcome? So an API is an interface, a small one, that allows unrelated software programs to communicate with one another. They act as bridges between two applications, allowing data to flow regardless of how each application was originally designed. For applications that function by pulling a constant stream of data from one or more sources, an API is especially important to decrease development time, save storage space on endpoints, devices, and overcome any differences in the standards or programming languages used to create the data that lives at either end of the bridge. So a quick example that might be familiar from more of a user outside of healthcare is the travel sites Expedia or Kayak. So those sites don't generate any data on their own to deliver comparison of flight information from 10 or 12 or however many airlines are representing. They simply use the API provided by each individual airline to plug into the flight schedule software for each company and pull that information into a single view for the end user. So thinking about how facile an API can be and help aggregating disparate data and putting that into a single view, thinking about the Expedia or Kayak example might translate to where your disparate data sources are in your organizations and how an API might help in the application data needed for that. Healthcare organizations are facing challenges accessing and sharing data, especially as health IT infrastructure migrates to the cloud and digital information becomes an industry standard. There's different data sets using different formats, making interoperability between apps a challenge. So there's no such thing as one set of data that gives you everything you need in a single format, and I know the people on the call know that. There will always be information coming in from a number of different places, and there will always be a need to work with systems that handle that. But because APIs are the points of communication between systems, they're being developed to simplify that interoperability to provide health professionals and users more efficiency. So HL7 is currently developing a FHIR data standard as part of the API, which provides a standardized way to aggregate and merge patient health data from separate data sources. FHIR creates the standard to make it easier for professionals to use and share the clinical data by restructuring the healthcare data from different sources into a compatible format for easier interoperability. So as healthcare becomes more digitized, patients move around their health ecosystem, the EHR must be available and discoverable and understandable. So further, to support automated clinical decision support and other machine-based processing, the data must be structured and standardized. While FHIR is not widely yet available in healthcare as it could be, the importance of APIs is high priority for the ONC, as we talked about before with the Blue Button 2.0 initiative, and which is included in technology in the most recent EHR certification criteria. This slide is from Health Data Management. They just recently did a study of 160 responses from provider organizations in late 2018, and it's showing the importance of interoperability and also the effectiveness of how these providing organizations feel about the interoperability and the opportunity there. Different data sets, as we talked about, use different formats, making it interoperability between apps a challenge. The ONC's report on interoperability made 3 recommendations for future actions to accelerate the progress we talked about, and focusing on improving and upgrading technical capabilities of health IT so patients can securely access and aggregate and move their health information is going to increase that transparency that's also being driven by the consumer need and the reimbursement models that are being formed around the patient at the center. So we talked about CMS moving from meaningful use to promoting interoperability as the program. And they're going to provide, they're hoping to, the goal is to really provide more flexibility and reduce some of the burden by placing a strong emphasis on the measures that require the exchange of health information between the providers and the patients. As those that have lived through meaningful use, which I have as well, it was very cumbersome. It was an additional work outside of the work you were doing within your hospital systems to get the meaningful use work done. They're trying to move toward promoting the work of submission to be consistent with promoting interoperability and moving toward that goal. So there's a 90-day reporting period like there has always been, and CMS can confirm the EHR period to be the calendar years between 2019 and 2020 for new and returning participants attesting to CMS at their state Medicaid agency. Performance-based scoring methodology for the Medicare Promoting Interoperability Program. So the rule finalizes a new performance-based scoring methodology consisting of a smaller set of objectives that will be more flexible, less burdensome, allowing eligible hospitals and critical access hospitals to place their focus back on the patients. This is a slide that's showing the 4 objectives and what they're going after at a high level. E-prescribing, they're proposing 2 new measures, query for prescription drug monitoring and opioid treatment. The important one that's supporting interoperability, all these again are really supporting interoperability, but the summary of care has been one of those transition of care documents that's been heavily tracked. And so they're proposing a new measure that the functionality of the existing request accepts summary of care and clinical information reconciliation measures into a new measure to support the electronic referral loop by receiving and incorporating health information. The third one is provider to patient exchange, where that's going to promote patient awareness and involvement in their healthcare needs through the use of APIs, which will improve the flow of information between the providers and patients. So the patients could collect their health information from multiple providers and incorporate all their health information into a single portal or an application or a program or other software. This can support that patient-centric view and have them share their information with another member of their care team or with a new doctor, which can reduce duplication and provide that continuity of care that is elusive and also ensure that patients have access to their medical data. And the last one is the public health and clinical data exchange. It's part of that, the syndromic surveillance measures, where it's supporting the systematic collection and analysis and interpretation of the data that might be used in prevention and controlling of disease. Eligible hospital or acute care hospitals will be required to participate in this measure. HIMSS has outlined 3 levels of interoperability. Other entities are forming their own definitions. There's more than 3. There's different wording for them. But since we're in a HIMSS webinar, HIMSS has supported these 3 levels, the first being foundational interoperability. This refers to situations where data is exchanged between many different health IT systems without the systems necessarily being able to interpret the data. So Cloud Fax is an example of foundational interoperability. You think of that as serving at the very base of the communication as we move toward interoperability. Structural interoperability is the next level. That's a step above foundational, and it denotes systems also are able to interpret each other's data, move it in a uniform way to prevent any alterations to the outcome of the data. So as the middle layer, structural interoperability defines the format of the data exchange that takes place between the systems. It defines the syntax of the data exchange. And the last is semantic, and that is the top tier. This allows the data and information to be moved, interpreted, and really importantly, acted upon. So the information is shared across multiple systems and programs without losing data fields. It's allowed to be interpreted and used to improve quality, safety, and accuracy of the patient care. The capability aims to create a common vocabulary that enables accurate and reliable machine-to-machine communication. Coming back to Cloud Fax a little bit to visit on how that supports foundational interoperability. So interoperability is expected to be a key enabler for population health and alternative payment models, delivery reform, and improved performance measures. We talked about CMS, promoting interoperability programs, and insurance companies are also mirroring their payment models and risk models to form into these programs that are necessitating accurate data submission to get full reimbursement. So Cloud Fax achieves the foundational interoperability because the EHR system can receive the data from another system but doesn't need to be able to interpret it. So digital fax file formats are standard, which means that the digital fax system can read any digital fax and produce digital faxes that can be read by any other digital fax system. They use standard file formats. They can even use a transmit, comment, and format for images and searchable documents such as PDFs. And these files are encrypted. In other words, the voice over IP has already partially solved the medical records interoperability problem. This is a slide showing, as part of the sponsor of this program, the eFax corporate family and their 3 cloud faxing solutions in the suite that are HIPAA compliant, out-of-the-box solutions to help with major data privacy laws for healthcare. The solution meets regulatory broad standards for in-transit and at-rest encryption, record keeping, auditing, chain of custody, limited use of data, and access restrictions. We are going to be participating in HIMSS in a few short weeks, and we are at booth 7245. If you would like to come by and say hello, we would love to talk more to you and learn from you about some of your challenges that you might be having and successes you might be having as well, and how we might be able to support your cloud workflows with Cloud Fax. Thank you.
All right. Thanks so much, Brenda, for a really terrific and very informative presentation. Would like to open it up for questions now. We've already got a couple in the queue, but we encourage you to add more of your own, please. Just type them in the questions box and click submit, and we'll get to as many as we have time for. Brenda, first up, just kind of some basic definitions of terms, perhaps, for those who may still be unclear. What's the difference between health information exchange and interoperability?
Okay, great question. So a health information exchange is a vital part of modernizing the healthcare system, but it's not the same as interoperability. So the transport standards are important to achieving the health information exchange. Think of the transport, the encryption, the things that are needed to get the document through. But that is not really going to get us to true interoperability unless we continue our work in developing standards which support the need for interoperability and data use.
Excellent. Someone else here is wondering, which is a better way to send a document, cloud fax or email?
Hey, so the benefits of cloud fax versus email is when you send via cloud fax, the documents are considered legally binding. The faxes can include a physical or digital signature that's also binding. Again, cloud fax complies with HIPAA and outside of our industry, SOX, GLBA, and more. Cloud faxes don't get blocked. They, in the spam or viruses, they also keep your data private with end-to-end encryption. And the last thing electronic faxes can help with, or cloud faxes can help with, is they're sent from a secure portal, so that's another added layer of encryption.
Excellent. As we wait perhaps for any other questions to filter in, any other points that you maybe would like to reemphasize or revisit, but as we kind of wait a little bit?
Sure. First I want to say this is a lot of information, and I think this is a journey. As I started my career as a nurse and have migrated into more technology and business roles, it still is all about what happens at the point of care, and it's about the quality, safety of the patient and keeping the care team united. And so my hope is with this presentation, as you think about cloud faxing, think about where that might make sense in your workflows today. Where is a fax machine today? And perhaps there's an opportunity to lift that physical fax machine into a mobile device or your desktop, depending on how you work. Many, many people in healthcare, as you know, work on the move. So mobile is a natural enabler of cloud faxing and communication. We talked about the APIs and the standards around that. That's a work I think we need to think that continues alongside of what fax allows us to do today. So I think about providing a digital roadmap. If you are, and it's quite great if you're using fax today still, as many providers are saying it works and that's how we make our money, maybe there's opportunity to help you move to a more fluid solution in the cloud faxing environment where you might be liberated from that paper placement in your organization. And some of the things I also exposed in the way of digital direct messaging and APIs are also along that digital maturity map if you think about what your organizations are thinking about on their cloud strategies and where your important work might lie in there. I will be at HIMSS. I would be more than happy to meet with you if you're there or your representatives are there to help sketch out what your environment might look like in a digital, like I said, a roadmap. It doesn't all and shouldn't all really happen all at once. It's a lot to take in, so I see it as a journey.
All right. Well, I'm glad we took a bit of extra time there because we got a couple extra questions. First up, someone is wondering, about this concept of health information service providers and wondering, if you see them perhaps even replacing email service providers, such as Gmail or something like that.
They can, because the functionality is quite similar. The benefit of the direct is that layer of security and encryption. So it's, I guess you could look at it as you have more if you don't already need it. It is a way to exchange email, basically. The rate limiter, if you will, or the consideration is that you have to be sending it to somebody who also has a direct address. Now, that direct address doesn't have to be within your HISP. It can be another HISP that you're hooked to. But, for example, in Gmail, you can send it to anyone, right? You can send it to any email domain. Within the direct community, you're limited because of the high level of encryption and the controls that need to be safeguarded in your email exchanges. You're only able to exchange it with people that are in your direct community.
Right. Right. Okay. Another person here says he's kind of interested in that Kayak Expedia example that you used earlier. He says data here is likely a lot more simple than patient or payer data. Is there a promise for really utilizing APIs for truly sharing or integrating healthcare data among healthcare entities with disparate EHRs, et cetera?
Well, so I can speak to it from, like I said, what Verma put forth in the Blue Button 2.0 for their work for APIs, and there's a commitment to build the APIs with HL7 FHIR standards and the OAuth beneficiary authorization. I know my company and the partners that we work with, that is how we build our things. We are deeply invested in API strategy. It's, we know we have limited resources, and we know that there's a lot of people that have done different things much better than we have. We have a core competency, like many organizations, but we aren't proficient, say, in analytics. So we want to partner and have a plug-in for our uniform view going forward, to have and maybe the analytics play be with an API, or I'm in talks with texting, to have a texting patient care team application, mobile application, also have our API embedded so that you as a user would be able, as an example workflow, if you have a referral from a physician, that particular fax referral, cloud fax referral, would enable text alerting within a patient care team. APIs are a big strategy that even the EHRs are using now for the same reason. They can't build everything, although I'll have one holdout. I would say Epic's a little bit of a holdout on that. They're not as fluid, I would say, as the other EHRs I'm talking to about API. In the EHR community, they're putting together like Apple Store type of environments where you can go in and use your sandbox and build your API and then populate it there. So if you're going in and want to use, you have Cerner and you want to have J2 API, we've already done the work with doing a sandbox, doing some regression testing within that environment. And by no means are we the only one. So that is by far in my partnering conversations, the work of integration and partnership is through APIs, and there's a lot of exciting things happening to bring things to market with more best of breed without having to buy a whole best of breed. Now you just can buy the plug in the wall into your sort of Expedia experience, and you can have an analytics, if you will, or a cloud faxing, if you will.
All right. Well, again, this was terrific, really great stuff here. So thank you once again, Brenda, for your presentation, and thanks, of course, to the audience for joining us. At this time, we will wrap up, but please, on your way out, be sure to complete the evaluation that will be popping up on your screen at the conclusion of the event, just to share your thoughts and feedback with us. And a reminder that today's session will be available on demand for 1 year through the HIMSS Learning Center. Thanks again to everyone, and have a great weekend.